Welcome to Conversations in Lung Cancer Research, a Thoracic Oncology Group of Australia podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name is Tim Clay and I'm a medical oncologist at St John of God Healthcare in Western Australia, and it's delightful to be the host of this episode of the podcast. I'd like to start by acknowledging the traditional custodians of the land on which we live and work. We pay our respects to their elders past, present and emerging. We also extend that respect to all Indigenous people. In today's episode, we're going to be taking a look at Anaplastic Lymphoma Kinase positive lung cancer, therapeutic strategies and strategies for treatment sequencing in the Australian environment. And I'd like to thank our sponsors, Pfizer, for sponsoring this podcast. I'm delighted to be welcome on this episode of the podcast to luminaries in ALK positive lung cancer in Australia. My colleagues and friends, firstly Professor Ben Solomon, who is a medical oncologist at Peter MacCallum Cancer Centre in Melbourne, Australia, and has been a leading author on many of the pivotal papers in ALK positive lung cancer. And Associate Professor Malinda Itchins, a medical oncologist and clinician researcher at Chris O'Brien Lifehouse and Royal North Shore Hospital, and I'm sure they're well known to many members of this audience. So ALK-positive lung cancer is a relatively recent addition to the lung cancer space, and it's interesting to think that this genetic event in lung cancer was only described in 2007, so less than 2 decades ago. And the pace of development in this space has been nothing short of amazing. It's a condition that affects around 400 to 500 Australians yearly on a new diagnosis, but one with excellent survival outcomes and now significant survivorship issues. And I might start just by turning back sort of history a little bit and asking Ben to describe what it was like being involved in the early ALK space studies and how the fields developed, given that you were there from almost the very start.
Thanks, Tim, and a pleasure to be with you and Mel on this podcast. Yeah, I think you're alluding to how old I am, but yes, around 20 years ago in 2007, we happened to be doing a phase 1 trial with a drug that eventually became crizotinib, and the study was designed as a study with this drug, which was a MET inhibitor, but it happened to also inhibit ALK, and that same year, a Japanese group identified ALK gene rearrangements in a subset of non-small cell lung cancer patients, and the trial rapidly pivoted to enrolling patients with ALK rearranged lung cancer. The pace of progress was rapid, and there was demonstration on the basis of probably just over 150 patients of efficacy, which led to FDA approval of crizotinib for ALK-positive lung cancer, and subsequent phase 3 studies really established initial therapy with an ALK inhibitor as standard of care. And since then, as I'm sure we'll discuss, we've seen the development of second, third, and even fourth generation ALK inhibitors.
Malinda, who gets, or who is an ALK-positive lung cancer patient? When they come into your clinic, what are you expecting to see? Is there a stereotypical mold?
Yeah, thanks, Jim. Well, yes and no. I think thankfully in Australia now, everybody with lung cancer, particularly non-squamous, should be reflex tested for ALK. So all comers, and I've certainly been surprised a few times by some people I look after with ALK who may be quite elderly or previous or current smokers. However, ALK lung cancers do have a bit more of a propensity to certainly affect younger people, higher prevalence in women. I think from the literature, we've seen that in Asian and non-Asian, the prevalence is about the same, so 3 to 7% we would expect. Certainly, we know about ALK, some other things such as brain metastases can be a feature, and they're generally mutually exclusive to other oncogene drivers. But I say generally because I've got a lady I've just met who's got both an EGFR and an ALK. So we're certainly getting a lot more genomic information that's helping us understand our lung cancers better and better.
So, Ben, when you meet an ALK patient, what would your standard workup be for them in terms of assessment?
I guess across the board, it's important to get sufficient tissue for molecular testing. With ALK junior arrangements, we can identify ALK through immunohistochemistry, but more and more as we're moving to NGS, which has the ability to look at multiple oncogene drivers. I think that's what we would like to do. In terms of staging, I think it's important to assess the brain, ideally with an MRI, because of what Mal referred to, the propensity for brain metastases in this population. And as we'll discuss, there are a range of ALK inhibitors that are approved and available for use. So I think it's important to have this information before we start treatment.
And Tim, just a point to make about sort of the extent of disease with ALK. I think we've all had experience, unfortunately, it often presents with advanced disease and people can be quite unwell, and often because they're young and have been able to compensate with symptoms. But I'm certainly finding, as we all are, that the pattern of distribution of disease can actually be quite wide and varied. Often in ALK, it might be a small and not so conspicuous primary, but big, bulky disease elsewhere. And, thyroid metastases, bowel metastases, adnexal, pancreas, kidney. ALK can certainly have tropism, to some interesting parts of the body. I'm thinking of some unchoroidal metastases. So I always think ALK as well, if there's a bit of a bizarre pattern of disease.
I've certainly seen more than a few cases of, very small primary tumours where you look and wonder if that is even the primary but disseminated disease. Do you see much thrombosis at initial presentation, Mal? Is that a common feature of presentation?
Well, Ben's group first described it, certainly in an Australian context, and that's been formally looked at. And we know in gene fusions, certainly thrombosis can be a manifestation. We also see this in ROS. I think it's been quoted to be as high as 30% may have a thrombotic event as the harbinger even of their diagnosis. So yes, we always think about clots.
I might ask, we've got a number of ALK inhibitors that are approved in Australia, starting off with crizotinib, and then a historical footnote of ceritinib that came and passed very quickly and was not a fun drug to prescribe, onto the second generation inhibitors of brigatinib and alectinib, and then most recently lorlatinib. So Mal, I might ask you to sort of just discuss what was our previous standard for a long time of alectinib or brigatinib and how those drugs became the sort of the standard of care.
Yeah, thanks, Tim. So I guess, as you may be aware, and everybody aware, that unfortunately and fortunately, the pace of drug development in ALK has meant that we haven't got great comparators of ALK inhibitors, and the next generation inhibitors have all been compared back to crizotinib, which was superseded some time ago. But obviously, we saw from the ALEX study, from the outer first-line study with brigatinib, the phase 3 data, really those landmarks for survival hit home as being extremely positive, as well as CNS prevention of progression, I think was a real need. We saw in crizotinib, very active drug, game-changing, but 70% progressed in the brain. We also saw quite favourable tolerability profiles in those second-generation ALK inhibitors. So thankfully that pivoted us to have PBS access a little earlier than some other parts of the world. I think it was 2017 and 2018 we were able to get those second generation inhibitors. So really strong landmark surrogate survival data push the needle.
And with your second generation patients, we've still got a number of sort of patients that started as a legacy on second generation inhibitors. Have you got many patients that are still on alectinib and brigatinib now? And how do you find them in terms of drugs for people that are on them for 3, 4, 5 years in terms of long-term or late toxicities and managing them in the clinic?
So as Mel was saying, the results with the second generation inhibitors are pretty impressive, with alectinib 34-month median PFS and 5-year overall survival in excess of 60%. So these are very effective drugs, and they've certainly changed the natural history of disease. And as you've mentioned, there are lots of patients who are still doing very well on these drugs. And I think patients and clinicians learn to manage toxicities over time. I think even drugs like alectinib do have have toxicities. They have some of them are, I guess, paper toxicities like liver function test alterations, but side effects such as myalgias, weight gain, edema are real things, even with the second generation inhibitors. And I think these are important for clinicians to manage so that patients are able to continue to get benefit from these drugs.
Yeah, I think with alectinib, as we've had sort of more years of experience, the weight gain is more substantial than perhaps has been reported in the earlier readouts of ALEX and the other phase 3 data. I certainly do have more and more people in the clinic that weight becomes our predominant discussion, but that's years on drug. And generally, we've stayed on it because it's treating them very well. Brigatinib is well tolerated as well. I think it just came a little late with the phase 3 data coming after the event. When you really tease it down, it's a very brain active ALK inhibitor. And we did the studies at North Shore, and I think those that have remained on brigatinib are also, doing equally as well.
And Mel, when you have your patients who are progressing on their second generation inhibitors, is there a standard pathway that you follow in terms of assessing them and what to do next?
Yeah, so I guess as probably you do as well, I like to get a more comprehensive look with an MRI brain and a PET to understand truly what's going on biologically, to assess what progression looks like, if it's one site, multiple sites, or polyprogression, what our priorities are. I think at that point, I'll generally try to get a tissue biopsy just to understand, again, what's changed in time. And that may be different what I'm asking for based on how long they've been on drug. Of course, in polyprogression, and if things are looking like they're marching, you want to have a look for histologic transformation. This certainly can happen as our targeted therapies become more potent. I haven't had any small cells myself, but I have had a squame transformation, so it certainly does happen. So that's really important to understand. I mean, the first thing we're always wanting to know is, can we give a local ablative therapy? In some circumstances, that may even be a surgery, for example, in adrenal progression, if that's the only site, and that can give us also some, diagnostic tissue as well. So I'll always be wondering, can we do something, to ablate progression, given ALK is such a heterogeneous disease, but always wondering as well if we need to do a drug switch. And I may bring in a liquid biopsy at that time, which, as we know at the moment, needs to be funded usually by the patient or on a clinical trial. And that might glean a further layer of understanding what it is that's driving the resistance. Is it still ALK, or have other mechanisms of resistance, non-ALK, emerged?
Yep. Ben, where would you go to after a second generation inhibitor? Well, having done all the work up to understand why you've got progression.
Yeah, no, I would take a very similar approach to Mal. And I think in the context of oligoprogression, although I think local therapy is appropriate, my threshold for moving on to a third generation has lowered. I think the real sort of utility of, I guess prior to the availability of Lorlatinib or third generation inhibitor, you try to sort of increase the time on your current generation inhibitor. But now we know we've got another effective systemic option, not just for the site that's progressed, which you've treated, but potentially other disease. So I'd say my threshold has dropped, but I do think locally ablative therapy is important. And just sort of incidentally, we're sort of thinking about moving this sort of earlier in the treatment paradigm. There was a study of local therapy actually with brigatinib called Bright Star. And that study showed the sort of benefit of consolidation local therapy, either radiotherapy or even surgery, as Mel alluded to, in sort of keeping patients on treatment for longer.
How have you mentioned going on to third generation inhibitors there, and specifically referencing Lorlatinib? How does Lorlatinib perform after a second generation inhibitor in terms of efficacy?
Yeah, so this was looked at in the phase 1/2 study, which with Lorlatinib and led to its initial approval after second generation inhibitors. And the efficacy was with response rates in the order of 50%, with CNS activity that was similar or greater, and a median progression-free survival of around 7 months. So it was sort of effective in that context. But I guess the bigger question, and one we'll get to, is where can we get the maximum benefit from treatment with a drug like lorlatinib? And the benefit post second generation is significant, and I think we've all got patients who've had years of therapy post second generation on lorlatinib, but I think now we're sort of learning that it's best to use our most effective drugs early on, and ideally in the first line setting.
I agree, because when you look at that data, 1 in 5 don't respond. And really the people that do well are those that have those on-target ALK kinase domain mutations, G1202R being the notorious one. And they've generally cycled through more than one previous ALK inhibitor. So couldn't agree more. It means that we need to use the best drug first.
Ben, sort of leading the witness here, how does lorlatinib perform as a first-line drug?
Yeah, so there's the CROWN study is a study that was looked at, and we recently, well, not that recently, about 2 years ago, got the 5-year results, and we'll likely get an update very soon about the study. But lorlatinib was very effective systemically and in the brain, and I think what sort of really stood out was the durability of the responses with lorlatinib. And at 5 years, 60% of patients were remained free of progression, and that's not something we've seen with the targeted therapy before. And the Kaplan-Meier curves in the lorlatinib study almost look like there's a tail in that curve, but I think we need longer follow-up to look at that. And I think another important factor is how effective it is in the brain, not just for patients who have brain metastases, but we know that ALK-positive lung cancer, like actually other subtypes of lung cancer, have a propensity to develop brain metastases over time, and lorlatinib is pretty effective in preventing that from happening.
Mal, is there a situation where you might choose a second-generation inhibitor over lorlatinib?
I knew you were going to ask that. So we're going to move on to what's happening in the 4th-generation ALK inhibitor space, and Ben and I have been involved in the neladalkib ALKOVE studies phase 1-2. What's interesting is the phase 3 opening in that space, Alcazar, is actually randomizing neladalkib to alectinib. So we're not going to see randomized data that we're aware of with lorlatinib. So then I had to think to myself, who am I going to put on that study to go on to alectinib? Because at the moment, probably the people that I would suggest alectinib to are those that are older and a little bit cognitively impaired, or of course those who may have mood disturbance that is uncomfortable. But I would say actually my lorlatinib experience and the way that we're learning to, drive it, I think very safely, I'm finding the people I'm looking after who have a mental health history are actually doing quite well with lorlatinib. So for me now, that's not an absolute contraindication. I'll generally start low, 50 milligrams, keep a close eye, and 75 milligrams is where we often land. For context, 100 milligrams has been the internationally registered dose. However, when we've looked at it, 75 milligrams really performs quite well against 100. So I bring that up because lorlatinib, as we haven't spoken about yet, the neurological toxicities is certainly peculiar to lorlat and probably has something to do with its effect in the brain and on TRK as a pathway. And I think when we're counselling patients, we're always really cautious around talking to them about potential mood disturbance, some memory impairment, and even some speech disturbance as well. I say that and I have speech disturbance. So I find that I spend quite a lot of time talking about that, as it can often be low grade, and these people are usually still working and obviously wanting to have good quality of life. And often some of that history comes actually from their caregiver or loved one when you're trying to understand how they're impacted with the potential neurological side effects of lorlatinib.
How about you, Ben? Do you go in at 100 milligrams normally, or have you taken a more nuanced approach to initiation and dosing?
Yeah, my usual starting dose is 100 milligrams, but more and more I've been sort of considering starting at a lower dose in exactly the situations that Mal described. Patients with some sort of potentially elderly patients with with less cognitive reserve, patients with a history of psychiatric illness, maybe patients who are more socially isolated. But I was on a panel with a psychiatrist, and I mentioned sort of mental or sort of psychiatric disease as a contraindication, and the psychiatrist is keen to point out that it's not an absolute contraindication, and if you do feel that it's the best drug, there are ways to sort of in conjunction with the psych team and getting support to manage those. So I think Mal's point about not having absolute contraindications is relevant, but I do think, as she also said, that it does mean that we do need to work hard in educating the patient, their carers, about what to look out for, and be very proactive in dose reduction and managing toxicity, dose interruption and dose reduction, and managing tox.
Mal, are there any other major toxicities with lorlatinib that we should be monitoring for or managing?
Yes, well, often unanimous with taking the drug and being compliant, the cholesterol zings, and we're pretty comfortable with that now. There's a number of statins that are safe. Rosuvastatin's the only one I can really spell, so I'll generally give that and I'll push it high. Sometimes, though, we know that people don't tolerate statins so well and they get some myalgias and we don't know what's what, and the next class may be ezetimibe. I mean, I would say that I don't go for Olympic cholesterol levels. I think just keeping the cholesterol certainly in single digits is important. I don't know that we've seen data yet that having, a slightly raised cholesterol in this circumstance correlates with accelerated cardiovascular disease, but we're still obviously mindful. So cholesterol, glucose as well. Weight gain is common. Weight gain is very topical and very challenging. I think that obviously we motivate people to exercise, as well as, helping them to understand it's a common side effect. They'll often put up with it, of course, a bit, because having good cancer control is really important for their overall quality of life. I think Ben alluded to edema can happen certainly with lorlatinib, some peripheral neuropathy. There are people that certainly I need to give some pregabalin to. That's quite common in my clinic actually of a week, but we generally get it under control. And then the usual ALK inhibitor class effects, some liver dysfunction, of course, may need to be managed. They're the main ones coming to my mind for lorlatinib. Ben, back me up.
Yeah, no, I think those are the key ones.
Is there anything sort of Mal, from initiation of lorlatinib where you can give the patient some clue as to how they might do? I mean, certainly we've got long-term survivors, but are there patients where you worry that despite using your best drug, you might not get as long out of it as you would expect?
Yeah, absolutely. I think that for us in the clinic, we look for biomarkers and an understanding of who may not be hitting that median, which Ben has alluded to. If it's 60% at 5 years, great, but there's 40% that are not making it to that 5 years. So I take a look at the molecular report, and from the Crown data Ben presented, we do see those that have co-mutations, TP53, they are the ones that may have an earlier progression point. And although we're not doing it routinely in the clinic, those that have positive liquid and don't clear their liquid, on their initial restaging, they're another group that may, of course, not have a sustained effect with lorlatinib. So there's some biomarkers I'm thinking of. Certainly clinical response. So lorlatinib works really quickly. So people that are in pain or have various symptoms from their cancer start to notice a response on the same day. So I don't linger with lorlatinib. If there's something going on where they're not clinically responding, something isn't adding up. There's something discordant going on. I think you get such an early barometer of response by the way, people are feeling. Unfortunately, big burden disease, although they tend to have excellent early objective responses, they're also the ones, unfortunately, that may progress out a bit earlier based on, the number of sites of disease. I tend to watch those people a little earlier. I'll always do an early MRI brain just to see that we're winning, expecting really good responses in the brain, as we've heard, as good as the body.
How early would you go, Mal?
Yeah, so driving's really important, right? I hate talking to people about driving, but if they have cancer in their brain at diagnosis, it's different in every state, and if you haven't had a seizure, still you're not supposed to drive until you're responding. So I'll do one at 6 weeks if you have CNS disease. I'm in a privileged area where I can get MRI brains. I acknowledge that that's not easy. But I think that these are, often people that want to get back driving their kids to school. And so we really do spend some time making sure CNS is rock solid.
Yeah. Ben, how about you? How do you follow your patients up on Lorlatinib, both in the short term and the long term?
So I guess we do know that about 30% of patients do have progression in the first 2 years. So this is what some people have termed bad ALK, and understanding the biology of this, being able to predict it is really important, because I think we need to sort of work out how to intensify therapy for those patients, and perhaps not for the 60% that are doing super well after 5+ years. My approach would be similar to Mel. I would restage fairly early on, 6 to 8 weeks. Most patients are hopefully responding, and then I would do scans every 3 months. I have questioned my strategy, though. My routine was probably to do MRIs of the brain every 3 or 6 months. But having looked at the time to intracranial progression curves, particularly in the patients without brain metastases at baseline, you could argue that for those patients who don't have brain metastases, that may not be necessary to do.
Agree. I've generally adopted a bit less MRI brain surveillance, but I'll tend to do a PET or two, as many of us probably are, a year. As you alluded to, Ben, I think that there's a movement towards consolidation of metabolically persistent disease. Those data aren't all mature, but they're cooking. And I think we certainly do expect it will help us, no doubt, have much more durable control on just a tablet therapy whilst we're waiting on overall survival. That's nuanced at the moment, but PETs will be something I incorporate as well.
Yeah, I think that's a good point. But I will also sort of add that in patients on second-generation inhibitors, I think monitoring the brain with MRI is really important, because that's a frequent site of progression.
Do you space, if you've got your patient who's reached their 5-year mark and is doing well, would you start to think about spacing your scans out? Is that something you do early or not at all?
I must admit, and this is a discussion you have with patients, and patients get anxious about having scans, but they also get anxious about not having scans. And for most of my patients, we sort of have a sort of 3 to 4 month window, and the ones that feel more comfortable, we stretch out to 4 months. The ones that feel less comfortable are closer to 3 months. Not sure what you guys do in that context.
Well, you get one with 3 repeats of Lorlatinib. So they're coming back to the clinic earlier anyway. So I tend to certainly have that as our benchmark. I guess what you're saying, Tim, and I like that Ben has alluded to a tail on the curve, but unfortunately progression remains inevitable. And as time goes by, I actually tend to want to keep a little bit of a closer eye, as even some things can happen like an isolated CNS progression, which I want to pick up in an asymptomatic circumstance. I guess that's when we're starting to see some drug resistance bear out.
Yeah, I guess personally practicing across tumour streams and having some tumour streams where you get people who have demonstrated that they're a good actor, that I've tended to space things out a little bit more, the better someone's doing, on the basis that they've kind of declared favourable biology. But again, that's not really supported by, this is the art of cancer therapy or cancer management rather than the science. And I would very much agree that it's a discussion between clinician and patient about, but obviously with the experience of the clinician guiding things, but about where you set your benchmarks or follow up. And certainly I always tell my patients, even if they're feeling well, that if something changes, to get in touch with the clinic earlier if they're worried something is changing, so that we can intervene in a more timely fashion. And interestingly, there was a study several years ago presented out of France of routine versus symptom-guided management in advanced cancers. A slightly different setting, but showing that the patients who were reporting or filling out routine symptom reports had better pickup of their progression events, obviously in a disease that was more polymetastatic, but showing that patient-reported experience can be very useful for detecting progression. We've had a fairly long conversation, and I guess 2 areas that we haven't touched on in terms of medical management is what the future holds beyond Lorlatinib. And Mal, you've already mentioned the ALK study. Do you want to tell us a bit about neladalkib and where that molecule is heading?
Yep. So Nuvalent brought into the clinic NVL-655 that's now called neladalkib, and that's gone through its phase 1 and 2 throws, and it's fully recruited. And that trial enabled any number of lines, including treatment naive. That drug was developed for a few reasons, to be more potent on target, as well as to be active in a more difficult resistance circumstance, such as ALK compound resistance mutations that we certainly see with previous ALK inhibitors. It was also designed to have less of the neurological side effects, which certainly I think in the clinic we've experienced, and it is a well-tolerated drug. We've seen some of the data presented last year, and objective response rates look good. The signal is about 30 to 50% in a pre-treated group. But what we haven't seen so much yet, the important population, is how active is it after first-line Lorlatinib, having had one ALK inhibitor only early. And I think that's a group we're really interested in if it's going to have a position in sequencing. And then, of course, as I've alluded to, Nuvalent have moved it into a first-line investigation setting. In ALK, as we know, a phase 3 will take many, many years, but we'll await those data.
Ben, is TOGA undertaking any efforts to understand sort of resistance to first-line therapies?
Yeah, I think as we were speaking earlier, the sort of mechanisms of resistance are heterogeneous. Tumors can work out different ways to become resistant, and understanding that can help guide subsequent therapy. So we're hoping to launch in the next month or two a study called Aspiration to Liquid, which will allow patients around the country to have circulating tumor DNA in the context of progression on targeted therapies, and return the sort of information from the ctDNA analyses to clinicians and their patients to help them sort of guide decisions about subsequent therapy. And Mal and others are very involved in that study.
Yep. And Ben, the sort of disease state that we haven't touched on is sort of early stage disease, and with increasing availability of transaxial imaging in the community for a number of reasons, we're picking up patients at stage 1 and 2 and 3. How has the landscape for early stage ALK positive lung cancer changed in the last 5 years?
Yeah, so we know that for non-oncogene addicted cancers, we know immunotherapy in the neoadjuvant setting has had a big impact, but we don't think immunotherapy has the same effect in ALK or other oncogene-driven cancers like EGFR. There have been 2 phase 3 studies, one with alectinib and one with ensartinib, that have shown benefit of adjuvant ALK TKIs after resections. And I guess there are a couple of points worth mentioning. One is that often the disease is more advanced than suspected. Many of these patients have unexpected stage 3 disease. And the LENA study showed benefit of 2 years of adjuvant alectinib compared with chemotherapy. And there was a study with ensartinib, in which patients all received adjuvant chemotherapy and then were randomized to ensartinib or placebo, which also showed benefit. So we know that there's a role for adjuvant ALK TKIs, but how exactly to use it, what the role of chemotherapy is, what the optimal duration of therapy, I think are questions that we still need to answer.
Mel, if you have a surgically resected sort of ALK positive patient today, in the Australian context, how are you managing them post-operatively and discussing the nuance around treatment availability?
Yeah, well, just to make a point about rare cancer problems, we did have the Horizon studies in a number of Australian sites and around the world looking at perioperative alectinib with some chemotherapy. And unfortunately, those trials have been deprioritised and are no longer recruiting. So rare cancers have a problem that trying to recruit more data, understanding how to best manage also in the curative setting is challenging. So an ALK positive early stage cancer, which is hard to find, but we do find, upfront resection would of course be our standard. And then at the moment, there is the ALENA study that Ben has presented. We're expecting it on Medicare soon. And then I guess the next question is, what do we do if they relapse down the track, if they actually had systemic disease, which many ALK positive cases in fact do? We're not in an MRD space at the moment in the clinic, but I think depending on the nature of the relapse, most of them will happen after a period of drug-free interval. I would be pivoting them back onto an ALK inhibitor, no questions. And if they were to declare advanced disease after early, Lorlatinib would be what I would be going for in that population. And we've seen from ADORA, they still certainly respond, to targeted therapy.
But is Pfizer looking at any options for Lorlatinib in the perioperative space at the moment?
There is a Chinese study which is called Lauren, which used neoadjuvant Lorlatinib, and there was a complete pathological response rate of somewhere between 20 and 25%, suggesting it's certainly active in that setting. But beyond that, I'm not really aware of other sort of ongoing perioperative studies.
And similarly, locally advanced disease. I mean, in the LAURA study, we all saw how that standard of care curve looked, and I think that would be reminiscent of ALK if we had one to sit side by side.
So there actually was a study called Horizon 1 where patients with locally advanced disease after chemoradiation were randomized to alectinib or durvalumab, and that's completed accrual, and we'll await the results of that. I think no prizes for guessing which arm is likely to win.
And that's a challenge, isn't it? I mean, I think we feel pretty comfortable what we want to be doing also for locally advanced ALK post-chemo rads.
Mel, we get some patients who exhaust ALK inhibitors or for whom there is not access to another therapy. So what are the roles of other systemic therapies in ALK-positive lung cancer?
Exactly, Tim. I think that there may come a time where disease is driven by a more molecularly, diverse biology, where ALK inhibitors on their own we see aren't enough. I think in that setting, when it looks to a clinical trial right now, we tend to look at antibody drug conjugates. We certainly know that they can have bystander effects, and those that are looking most interesting in non-small cell lung cancer targeting TROP2 or HER3. So I'd think about an ADC on a trial. There are some other medicines coming through. So there is an ALK degrader glue molecule, which is coming into early phase in Australia soon, that looks at trying to break down ALK, from a different pathway than hitting the tyrosine kinase domain. Again, that's still ALK targeting. But I think for me in the clinic, a common conundrum is there can be mixed response. There can be a number of sites of progression that aren't truly, oligo progression. However, CNS may still be stable. And I think that's a group right now that are difficult because on Medicare, we don't have a clear pathway. The Boston group did put out a large series a couple of years ago of 150 odd ALK patients, and they were able to show meaningfully keeping your ALK inhibitor going, your CNS penetrant ALK inhibitor, and adding some chemo in a compel style can meaningfully, improve progression-free survival, overall survival by about 4 or 5 months, but absolutely prevent progression in the brain, which is so important for ALK. So that's something that I will do, but that's not in an on-label Medicare circumstance.
Ben, is there a role for breaking your ALK inhibitor, giving chemotherapy, and then coming back with an alternative ALK inhibitor after a sort of chemo interval? Is that an approach that might work?
Yeah, I think there is a sort of retreatment effect that can happen in that context, but the responses that you see tend to be relatively short-lived and not necessarily that frequent. So I do like the approach that Mal mentioned, the compel approach, where you bring in another therapy such as chemotherapy to deal with resistant clones whilst continuing the TKI to maintain control in the brain and at other extracranial sites that have been controlled. And I think that's something we should work to make more widely available.
And I've got a feeling on aspiration too, Ben, that might be a pathway we formalise, for a group of people based on their liquid assays as well.
Yeah, that's certainly something we're working towards.
The Thoracic Oncology Group of Australia receives wonderful support from our patient representatives and our patient advocates who help us design and run trials and provide insights to the most important group in this situation, who are the people that we're caring for. This podcast has been very much focused on past, current and future treatments for ALK-positive lung cancer, with a lens on informing interested clinicians how to care for patients. I do want to draw the listeners' attention to ALK-positive Australia, which is a patient-driven and patient-focused group that provides both information and support for people and loved ones with ALK-positive lung cancer as a resource you can turn to if you're looking for more practical information on ALK-positive lung cancer, lived experience, and seeking advice and treatment for your condition if you or your loved one has this particular type of cancer. I'd like to thank you all for tuning in to this episode of TOGA's Conversations in Lung Cancer. I'm very grateful to my colleagues Ben Solomon and Mal Itchins for their insights as clinicians treating patients with ALK-positive lung cancer, and we'd like to thank Pfizer again for sponsoring this podcast. You can find this podcast on all reputable podcast platforms, and if you enjoyed this show, please rate and review us on your platform of choice. Thank you for tuning into the podcast.